Good morning. Welcome to Medical Grand Rounds. It's a great pleasure this morning. I've been waiting for this presentation for several months now to have visiting presenter, Dr. Michael Mendoza, who is the Commissioner of Health for Monroe County, and he will tag team this presentation with Deputy Favata. So without further ado, Dr. Mendoza.
Thank you. Thank you very much, and thanks for being here. I see a lot of familiar faces in the audience, and so I look at this today as an opportunity to update all of you on where we are. I'd like to share with you, hopefully, a perspective that might be a little different, because as this has evolved over the last several years now, it's very clear that this is a complicated crisis, and one of the challenges that I see, and particularly in light of what's happening this past summer with the vaping crisis, another different crisis, what we're really struggling with is how do we think about addiction? And I think the root of all of this is really how do we come together as medical professionals and tackle the complicated issues around addiction. So I want that to be the backdrop. We often hear about the crisis, the epidemic, the outbreak even, and that's important, but I also want, especially those of us in the healthcare field, to be thinking about the long game here, because this is, in fact, a long game. So I want to talk about the broader context of addiction, how we got here, how I think we're going to get out of this, and what I think that might look like. Talk a little bit about the response that we've had, both in the county as well as in the community at large. And then sort of look ahead to the future and talk about what we need to do, I think, in healthcare to really address the root causes of how we got here. So let's be clear. The crisis that we're talking about is an overdose crisis. I took a lot of heat early on when I said that addiction isn't the crisis. Addiction is a chronic illness. It has been here a long time. When we use the word crisis, that evokes an image of all hands on deck, must do everything we can, and that there's a start and a stop. I believe there will be a start and a stop to the opioid crisis. I do not believe there is a start or a stop to addiction. And so when we talk about this, the media is all in on this. We have a window of opportunity as healthcare providers to get our message across. But I do think that when the overdose crisis is done, we will still have a lot of work to do. And I think it's important that you all hear from me as a physician that I think we own this. We take a major role in how we got here. And I show this picture at U of R also. This came in my orientation packet at U of R. Pain is the fifth vital sign, and I'm sure it was uttered even here. Pain, a fifth vital sign. And I will say, once and for all, there is nothing about pain that describes your vitality. Your livelihood, your vitality is in no way represented in the same way that a heart rate or a temperature or a respiratory rate might describe your vitality. So pain is not a vital sign. If you are using pain as a vital sign, please consider a different approach, because I don't think that has helped us. If anything, it got us to where we are. And where we are was helped by the Sackler family. The Sackler family owns Purdue Pharma. They are, I think, a net worth of $16 billion. They are filing for bankruptcy, if you can believe that, because they're worried about what might happen to them as a result of all these lawsuits. If I was the Sackler family, I would probably do the same thing. The reality, though, is that they fanned the flames of what we started in healthcare. And this is where I think a lot of our colleagues started to go off the rails. This looks like a valid, reputable reference, right? The title is self-explanatory, published in one of our most esteemed medical journals. And this article is right here. This is the letter to the editor, written in 1980, that was cited, as of last night, 1,422 times as evidence for how opioids do not cause addiction, or that narcotics are not associated with addiction. And this was propagated over and over and over again, primarily through the first 10 years of this century. to the point that this statement showed up on the bottle of oxycodone. It says very clearly, this is OxyContin, delayed absorption as provided by OxyContin tablets is believed to reduce the abuse liability of the drug. And we now know that's wrong. But this message got propagated over and over and over for 10 whole years, to the point that prescribing for opioid pain medications shot through the roof from 2000, really until now, but primarily from 2000 to 2010. And so what I'm showing to you here in orange, if you pay attention to orange, that's OxyContin. And it peaked in 2010. It's gone down since then. But if you remember 2010, that was nothing compared to present day as far as the opioid crisis goes. In fact, if you were to pull up a newspaper from 2010, I bet you wouldn't have even seen the word opioid crisis or opioid epidemic, because by today's standards, it wasn't really a crisis. It was a big deal. There were a lot of people dying from opioid overdoses, but it was nothing like it is today. So what happened in 2010? In 2010, the formulation for OxyContin changed, making it harder to crush and abuse, which was good. iStop came into place in 2011, I think, here in New York State, and prescribing started to go down, and there was a recognition among all of us in healthcare that we needed to do something about this overprescribing problem. And we did. When you put a group of motivated, incentivized people to stop overprescribing, that's what happened. And unfortunately what happened was we didn't realize that all along we were primarily medicating people's addiction, their opioid use disorder, with prescription pain medications. 70% of people who have opioid use disorder began with a prescription opioid. And so prescribing went down, but addiction remained. And so if you have an opioid use disorder, what do? You find a different opioid. And so that's what happened in 2010. 2010 here in the orange line is heroin abuse, heroin misuse. And that started to go up. Those are the fatalities from heroin overdose. Purple was prescription opioids. That sort of leveled off in 2010. But then came 2014, 2015, and that's where heroin became more expensive than fentanyl. And fentanyl, as you all know, is highly potent and lethal. The word poison has been used, and that is accurate. And that is the reason why we are in the crisis that we're in today. So addiction is not that much more common now than it was 15 years ago, but it is far more fatal. So the fatality rate from addiction has gone up, even though the actual prevalence of addiction has remained largely unchanged, or if anything, only slightly increased. And this is why. So this is a picture of a lethal dose of heroin compared to fentanyl, compared to carfentanil. So as far as we know, carfentanil is not yet in our community. It is in many communities around the country. But these are all highly lethal synthetic opioids. The fentanyl and the carfentanil are synthetic. They're not what we prescribe in the hospital. Carfentanil, this vial, by the way, is 2 inches tall. That carfentanil speck is enough to kill a human being. It is used as an elephant tranquilizer, and it is being found in a lot of the drugs that we're finding on the street. We'll get more into that later. To give you a picture of how it looks across the region, Erie County is unfortunately leading the pack. They got into this crisis a lot sooner. Their numbers have gone down faster than us. They've been thinking about this a little longer than us, but they are still struggling just like we are through how to get through this crisis. But there's a lot of variation. Most of the overdoses happen in the city or in the county, although most of these people don't actually live in the county. So there's a lot of migration in this epidemic, and we'll talk about that in a little bit. And these are the numbers in Monroe County. You know, this is hard to call good news, even though the numbers have gone down in 2018. It's hard to call this good news because this is still far too many. And, you know, we're going to release the 2019 numbers, at least the first 6 months of that, very soon. And, you know, we'll wait and see. But we still have a long way to go. And this is what's being found in the deceased individual's bloodstream after toxicologic analysis. On average, there are 3.5 substances per person in all of the fatal overdoses. So as you can see here, fentanyl is present in 94.9% of all of the fatal overdoses. So I'm calling this a fentanyl overdose epidemic right now, because this is really all about fentanyl at this point. So the way we're going to get out of this crisis is both by helping people to get out of the cycle of addiction, as well as getting rid of the fentanyl on the street. Prescription opioids here are 6th from the top, I think, so not that common, and probably not the reason people are dying. So this is a busy slide, but I like to show this in healthcare audiences, because I think a lot of healthcare systems are trying to address this problem simply by hammering on the prescribers to prescribe fewer opioids. And there is validity to that. We need to treat pain, and we need to treat pain appropriately. There's very limited evidence that using chronic opioid therapy for non-cancer pain, there is very little evidence for that. But if all we do is beat up on the prescribers, we will not get through this crisis. And so what I'm showing to you here are by county across New York State. In orange is the per capita morphine equivalents prescribed in that county, ranked from high to low. So orange is that line everybody wants to know. Sullivan County has the highest per capita prescribing rate. And then Kings County there on the far right is the lowest per capita. In blue is the corresponding opioid overdose fatality rate by county. And this is as of 2 years ago. There is no correlation between opioid prescribing and opioid overdose fatalities. And so if all we do is make that orange line shorter, I have no reason to believe that the blue lines are going to change at all. So let's talk about addiction. If there was one thing I could change about this crisis, it's the stigma that has been attached to drug use and to addiction. I think it is the reason why we are so late to the game in addressing addiction as a medical community. It's a chronic illness. How many of you remember this commercial? Yeah, I was there. There really wasn't much that was accurate about this. For those of you who are too young to remember, the egg was your brain and the frying pan was the drugs. They cracked the egg and it started to fry, and that was your brain on drugs. The only part that I think was accurate about that was that it was your brain was the issue. Addiction is a disease of the brain, and cracking it has nothing to do with this. It is a disease of the brain. And those of you who know radiology better than I will be able to understand this even better, but what I'm showing to you here are scans of normal, person without a drug use issue, somebody who's abusing cocaine 10 days after they've last used, and that same individual 100 days after their last use. The point I want to make here are several. One is that the brain is not normal after 10 days. Okay, that middle row is clearly different from control. And that's 10 days after cocaine has left their body, essentially. And 100 days later, that brain is still sick. And so for those who say that all we need to do is get people into detox, that's just the beginning. Getting people through detox and through recovery is a lifelong battle. And as you can see here, 100 days later, that brain is still very sick. And I think we all wish, there was a way that we could predict who was at risk for addiction. So the reality is that genetics account for 50 to 75% of one's risk for developing a use disorder. That's good news and bad news. The good news is that addiction is not that common. And so there are ways to beat our genetics. The bad news is it's really common, and a lot of people are at risk. And many of us in this room may be at risk, and we may not even know it. And that is what got us, to a large degree, to where we are today. And so this is somewhat of a busy slide, but the point of this slide is to show that the prevalence of drug use disorders has not changed all that much. So what I'm showing to you here is the prevalence of use disorders going back to 1990. And there are some increases, certainly in some demographics, from 20 to 24-year-olds, that's going up. But this is all drug use disorders, so this is all addictions. And it is not going up nearly as fast as the opioid crisis seems to be, and certainly not as fast as the overdose fatality rate has. But I show this because I don't have any expectation that this is going to change all that much as a result of what we're doing with Narcan and other efforts in the community today. We will have to have a concerted long-term effort to address this, and I think we're getting there, but we have a long way to go. And if all we do is focus on the opioid crisis and Narcan and in all of the efforts that we have ongoing, which are important, if that's all we do, we will make no impact on the underlying issue of addiction, which I think is really the medical part where we need to come together around. And so, in the last several minutes, I want to talk about how I think this is a symptom of a larger epidemic. What we're seeing in the opioid crisis is, in my view, a symptom of a larger epidemic. And that epidemic is represented here. This is life expectancy in the United States. And as you can see, it has gone up steadily with a couple of blips since 1900. But the last 3 years in a row, life expectancy has gone down. And if you think about what makes life expectancy go down, it's not cancer or heart disease, because those illnesses typically cause mortality in the later years. What causes life expectancy to go down across the population is when a whole lot of people in the middle years or younger years are dying prematurely, unexpectedly. And so 3 years in a row and counting right now. The last time it went down at all was in 1993. And anybody have a guess as to why? HIV and AIDS, yep. A lot of effort there. 1 year, that was it. Only 1 year did it go down through all of the HIV and AIDS epidemic. And we're 3 years and counting right now. The last time it went down 2 years in a row was World War II, soldiers. And the last time it went down 3 years in a row was pandemic flu, World War I. And that is what we're dealing with right now. And that is the extent of the impact on mortality, premature death, that we're dealing with right now. And I don't think that this is all because of the opioid issue. In fact, the CDC has now begun to address this, calling it the diseases of despair. So when you look at drug overdose mortality, alcohol-related mortality, and gun-related mortality, those three issues together paint a very different picture of an epidemic that I think we need to address. And we'll talk about the root causes of that in a little bit. One thing I want to say about the other two causes, alcohol misuse by far much more prevalent than any of the other addictive substances that we'll talk about. Major, major issue. And as to guns, big debate going on around guns. All I will say from a medical standpoint is that every day, the same number of people that were killed in the Las Vegas shooting die from self-inflicted gun suicide. Every single day, we have a Las Vegas shooting happening in our country, and there are no headlines about it, from gun self-inflicted mortality. So these are the deaths of despair. So when you take them all together, that blue line is what the CDC is calling a new epidemic, and it is a very concerted, it's not spiking, it doesn't look like an outbreak, but this is something that is lingering right now, and we need to pay attention to this. And so right here in Monroe County, as I see it, we need to really unpack the root causes of how we got into this in the first place, and I believe it starts in the very early years. And every 2 years in Monroe County, the health department produces the Youth Risk Behavior Survey. In this survey, we survey literally every high school student in the county, with the exception of a couple of districts who don't participate. All of the city schools participate, and we take a stratified random sample of about 1,900 students, and we do analyses. Both of these reports are available today. These were just put out, I think, 2 months ago. But both of these reports are available on our website. And the findings are stark. So first of all, let's focus on the positive. When we ask these students about protective assets, the things that provide resilience to them, that's a good thing. And it's not just a touchy-feely good thing. It actually has associations to better health outcomes. So when we ask these students, do you feel like you receive encouragement at school? Do you feel like you matter in your community? Do you have a non-parental adult with whom you can talk about complicated issues? When we look at those who agree or strongly agree with those statements, there is a lower incidence of alcohol use, marijuana use, vaping, and smoking. The flip side is the trauma. And adverse childhood experiences, in my view, have not gotten enough attention in healthcare. And if I could implement universal trauma screening, I would. because I think that is truly going to get at the root causes of so much of what befalls our youth. So we ask our students in the survey, for how many of these statements would you agree with apply to you? And I'll let you read them all a little bit there, but 42%, for example, of students report that they don't live with both parents, and so forth. And we ask these questions because they matter. And so we do a little bit of analysis, and we find that about 13% of students who responded in the survey report having 4 or more of these traumatic experiences apply to them. So let me rewind. 13% of students in this county report that 4 or more of these applies to them. If you read through those, I would dare anybody to wish any one of them on someone you know or love, much less 4. And that is the experience that our youth, high school students, are living with today. And so it's no wonder that these students struggle in school, and we have data to support that. But it turns out that that ACE score is very predictive of a lot of things, and I'm showing to you here the history of substance abuse or substance use ever, as stratified by the number of ACEs reported by these students. And I want to call your attention to the 4 or more. That 4 or more alcohol use ever is the blue, 71%. These are high school students. 71% of high school students have used alcohol for those who report 4 or more ACEs, as compared to 28%, which is still significant, for those who have reported none. So these traumas are important. These ACEs are important. And I would offer, are we doing enough in healthcare to even look for them, much less talk about them? And so as I see it, this is really an opportunity for us to come together as a healthcare community, as a community at large, and we've got to both tackle the acute crisis of overdoses as well as the chronic issues around addiction and trauma. And so, going to the first, the acute crisis, so the Monroe County Heroin Task Force, and Deputy Favata will share more about that, they put out a map every month, and this is the map, I think, of year-to-date 2019, simply to show that they have probably the most up-to-date data that are available around the opioid crisis. And as you can see, the overdoses, red are fatal, blue are non-fatal. They're happening all over, primarily in the city because that's where the population is. But these data are published every month. In the health department, we have a unique authority in that we can contact people in the setting of a public health crisis without obtaining individual consent. So obtaining an individual consent is HIPAA. And for an outbreak, for a measles outbreak, when we had the measles issue, September, we were able to call anybody we wanted to without getting consent because it's an outbreak. And in Monroe County, I've called the opioid overdose crisis essentially an outbreak. And using that authority of the health department, we are able to contact people following an overdose without their consent. We try to obtain verbal consent to talk to other people after that, but the initial contact from the health department is perfectly fine, and so we do that. I get an email every time there's an overdose in this county, and we put them on a registry, much like we have a chronic disease registry for diabetes and high blood pressure. We put them on an addiction registry, an overdose registry, and we do outreach. And we can't do it all in the health department, so our job is to make an initial contact, connect them with a peer, connect them with their primary care provider, connect them with whatever resources we can find in the community. And these are the results of what we've done since, I think, March. The vast majority of people are not interested, either unable to reach them or not interested. But for those people who we are able to connect and offer services to, peers seem to be the most attractive. So connecting with the peers seems to be the most common way people want to start off their engagement with us. And we follow them forward and trying to hand them off to various other healthcare partners and so forth. And this work is ongoing. It's relatively small, but we're hoping that we're making an impact. So in closing, I want to share a few thoughts about what is our role in healthcare. The emergency department is unfortunately the nidus of where all of this activity seems to happen these days, because all people who have an overdose find their way, not all, actually most people who have an overdose find their way to an ER. So the ERs deal with people who have just been Narcaned, who are post-overdose, who are largely speaking not really interested or really able to engage in care. They'll see people who are intoxicated. They'll see people who are in withdrawal. They'll see people who have related health concerns. And the question really is, how do we make the best use of that resource? The ER is not the best place to provide care for addiction. It is where a lot of people go, but the most important question is, how do we make that transition from the ER to the next place of care? And I will say that Dr. Grams here at RGH has done a great job connecting people from the ER with resources and Unity and other chemical dependency sites around the RGH system. You've done a great job here at Regional. But I do think that the issue really resides in primary care. In that this is a chronic illness, primary care doctors like me, are trained to treat chronic illnesses. And I think we don't do enough in primary care to treat addiction. But in primary care, we take care of people through the entire spectrum. And I think the largest challenge right now is not only getting enough primary care doctors waived and able to prescribe Suboxone, because that's the easy part, it's actually prescribing. How do we get these people from early recovery, not being treated, into our offices and into long-term treatment? That is the challenge that I think we have to address in primary care. So going from waived to prescribed, that's the challenge that we've got to figure out today. And then how do we integrate all of that into our usual office practices? Because taking care of addiction in a primary care setting is not going to be necessarily just like taking care of high blood pressure or diabetes. And the role of the broader community in this is huge. So when we think primarily about the overdose crisis, all hands on deck, law enforcement, the judicial system, peers, family, media, everybody is truly involved. And getting Narcan out there is important. It will get us through the acute crisis, but it will not be enough. And so I'll leave you with some of the current controversies. As I see it, we've got to grapple with how do we deal with an acute crisis and a chronic crisis. The window of attention is always focused on the acute, but we've got to keep shining the light on the chronic issue of addiction. Stigma. I think stigma lives at a lot of levels. I think we stigmatize patients sometimes, and I think the system stigmatizes patients sometimes. Why is it that in New York State you have to have a different article of, from the State Department of Health and for OASIS and for OMH to take care of a single person? Why? I call that systemic stigma. Is drug use a crime or an illness? I'll just leave that there. Narcan. I've had people in medical communities say, if you give somebody Narcan, aren't you simply enabling their illness? And that's clearly not true. But I've had people in medical audiences ask that question. It is not enabling, it is prevention. It is helping it's like calling EpiPens enabling somebody's food allergy. Makes no sense, right? And then treatment. The notion of medication-assisted treatment, right? We talk about Suboxone as being medication-assisted treatment. That doesn't make any sense because we ought to be calling insulin medication-assisted treatment for diabetes, and we don't. Why do we call Suboxone something different? It's a medication, just like the other medications that we prescribe. And then the thought of somebody being on Suboxone for life. They say, why would you treat an opioid use disorder with an opioid for life? Why would I treat somebody with diabetes with insulin for life? Because that's what helps them to stay alive. And that's what we need to be thinking about in healthcare. The whole necessity for a waiver. Why do we need a waiver to prescribe Suboxone? Why do I need to put my colleagues through 4 hours of training to learn how to use a medication that has essentially 4 doses? Insulin and chemotherapy are far more complicated than Suboxone, and we don't have to go through a 4-hour training to prescribe those. I think it's another example of systemic stigma. Why are we stigmatizing a medication and therefore the people who need that medication? Abstinence versus harm reduction. A lot of practices struggle with this. And this plays out in taking care of somebody with a use disorder and expecting that they're going to be completely drug-free. It's like saying somebody with diabetes is going to be completely sugar-free. You would never expect that. You hope for it, but you wouldn't expect it. And you certainly wouldn't kick them out of the practice because they cheated on their diet a little bit. Why should we be doing that for people with opioid use disorder? And then, scope of practice. How can we broaden the workforce? Because we do not have enough addiction psychiatrists in this community to take care of everybody with addiction. And we shouldn't. That's a lot of money, and there's a lot of specialty that we don't need. I do think that this needs to live in primary care. And I do think that my colleagues and I in primary care do need to step up and address this concern. So with that, I will hand the podium off to Deputy Favata. I will say that healthcare and law enforcement are two pretty unnatural partners. But this crisis has afforded us the opportunity to work together. And I have to say I've come away with a much greater appreciation for the role that law enforcement can play in public health. And I can't think of any better example than Deputy Mike Favata. So without further ado, Deputy Favata.
Thank you. So I brought pictures. I'm a police officer. I love to show pictures of what we do. So I'm actually going to show you fatal overdoses, investigations that we worked on right here in Monroe County. This is what we're going to see in some of the houses and how we actually led to these investigations. So we'll talk about the Monroe County Heroin Task Force. It's essentially three parts. It's enforcement, which everybody knows police do. Doing surveillance, doing drug buys, entries, all the fun stuff you see on TV, we actually really do that. Melissa Shoemaker here, who's one of my best resources with dropping people off, because I go out and get people who've overdosed and bring them into treatment. Like the coolest Uber driver you'll ever have. But I always say is, when they tell me no, they don't want to go, I laugh and say, well, I'm kind of like that annoying ex-boyfriend who won't go away, so I'll just be back here in a few days. And it's amazing, after the second or third attempt, I'll get somebody into treatment. And Melissa's been a big resource for that. But we're going to talk about the three parts. We have enforcement, outreach. So every single overdose that comes in, I get right away. If it's a fatal, somebody on our team is called out, and we start our investigations right there. And it is very rewarding at the end of the day. And I'm going to talk about some of the cases up here. And then the outreach and the education. Those are, in my opinion, the most important part. I mean, we hit 10 houses at once back in November. 4 o'clock in the morning, we set up on literally 10 houses throughout Monroe County. It didn't slow it down one bit. I mean, we took bricks of fentanyl that they didn't dump into a grease fryer. So I'll give you an idea. We go into a drug house, they'll have fryer set up in the kitchen to dump all the drugs in there to get rid of the weight. So they have somebody in there dumping them in there as fast as they can, because we charge in weight. We charge in that product. So it's one of the things that they're, techniques that they're using now. They stop flushing it because they plug the toilet. And I'm not the one that's going to go in. It's the new guy that gets the drugs out of the toilet. So we usually take a picture of him doing that too. So, and then the education. I mean, I spent the last 2 days at Spencerport High School in the health classes. I don't do death by PowerPoint. I show them pictures, tell them stories, explain to them that we're here to help, that, remove the uniform and understand that if you need help, I'm here to help you. I'll meet you. And I always make the joke, and it's funny because it actually happened last year out of Penfield High School. I said, look, I'll meet you at Dunkin' Donuts or Tim Hortons. No one will ever be suspicious of you sitting there with a cop at one of these places, but talk to me about what the problem is. So I had a young girl meet me and said that, she knows that her mom's struggling, the domestics of the police being at the house between her and her father. So I pulled all the jobs up and realized that the deputies never asked what the actual underlying issue is. It was always that fight over money, or her coming home late or leaving early, whatever it may be. So what we did was I went and met with the mom and got her into treatment. And I kind of followed how that student did in school, and her grades went up and she became stable. So you look at the effects that this has in the household, it's incredible. I mean, we'll never arrest our way out of this. I know that. I was on a narcotics team before this, and when the new sheriff came and said, look, we need to form a task force to fight this epidemic, figure it out, let's do it. Let's just throw whatever against the wall, see what it works, and this is what we came up with. So I did 12 presentations between 2 days for all the health classes in the school. And it's amazing, these kids don't blink. I show them a couple videos, show them different pictures. I don't show them these ones, obviously, but they get good reviews. And I'm actually going back to Spencerport today because one of the students reached out to the prevention counselor and said that she wants to talk to me. So, you know what, if we save one life there, it's fantastic. So I'm going to just kind of go through these pictures here. We're going to show, this is in one of the houses that we hit. Just these are all pretty recent photos. You notice that they're the little wax paper baggies. Every one of those was filled with either cocaine, heroin, most likely fentanyl. We haven't tested fentanyl. This is in one of the houses of a dealer. So when you buy your drugs, he gives you a handful, you're ready to go. So he gives you the means as well. Oh. We're not going to show that. So these are pictures again. This is one of the ones I show the kids about looking for track marks, looking for that friend that you may be wearing clothing that isn't right for the season. And I asked them if they know why. And they're like, no idea. I'm like, well, they're covering up the track marks. It's important to understand that. They don't want people to see. One of the pictures I'm going to show you, he injects it was injected into his foot. That's where his injection site was because he couldn't be traced that way. This was on the bed of one of the fatals. Again, you'll see the two decks right here. Those right there are about $200 worth of what's ended up being pure fentanyl. That was not heroin. When we talked to the roommate, they said, yeah, we thought we bought heroin. That's what the guy told us. So when we tested this, it didn't even show up anything. Everything came back as fentanyl. Again, another way, you'll see the packaging right there. This is how the drug dealer was handing out the drugs to this particular female. In this case here, you'll see that on the markings on those bags, we looked for those markings. That's an indicator of what dealer they're using. Now, my brother works for Greece Police. I always tell him that I'm a much better cop than him because he's like really high up there and just does a lot of paperwork as an investigator. But he called me and goes, hey, we just had a fatal overdose. And I'm like, send me pictures of the bags. What do you have? So he sent this. And I'm like, well, we're on 1-2 with the same bag. So now we know we got a dealer who dealt with two people within the matter of an hour and with two fatals on opposite ends of the county. So we ended up making an arrest on that within a few days. And this actually case was one of the ones that helped with the pawn shop. I don't know if you guys saw the news where we made arrests of the pawn shops. It was interesting that one of the lists that one of the owners gave this particular male needed DeWalt drills, garbage disposals, and a couple other items. And he said he'd give him $100 for those items. And this guy went and stole about $2,300 worth of product just from here in Monroe County. So if that isn't feeding this issue that we have here, again, same concept. You'll see that we're fortunate that this kid's 4-year-old son wasn't in the house. You can see his toothbrush up there. But this is him. He was found in his bedroom by the roommate. This is the one that was injecting into his foot. You can see the marks. We took that just because it's the best love story, The Notebook. But again, he also was smoking crack cocaine as well. The only reason I show this, you'll see the markings on the bag. That was another one of the things, again, we look for in our investigations. Now, this particular, where is it here? Let me get someone with the credit card. Okay. This particular one here, when the girlfriend called 911, he had already been there for about 2 hours. She saw him use, he said he hit the ground within, she said, probably 15 seconds. So that's how quick this worked. So he injected, was on the ground, she panicked, left, drove around for a while, came back home and called. And the scary part about that is if she would have called 911, we at least could have gave him Narcan and potentially saved his life. So it's one of the things we stress in our presentation about the Good Samaritan law. You will not be arrested for calling 911 if we find drugs in the house or if you're part of this overdose. When you see the syringe isn't that far from. Same thing with this particular male. It was still on his arm. It happened that quick. Within a few seconds of him injecting, he was on the ground. And he was there for quite some time. Because it was another one where the people that he was using with left. They don't want to be any part of anything, and they just take off and leave people. You'll see the spoon for some reason, and this is another unique one. This guy was actually using apple cider vinegar to melt the crack cocaine. So he heated up and he would inject hot apple cider vinegar with the product, which is beyond us why he would do that. And that same picture. So does anybody have any questions for me? Does anybody have any, you okay? You're like, yeah. Well, what I'll do is real quick is just understand is that I'm probably one of the most passionate, I say, in law enforcement about this. I absolutely love what I do. I was actually fortunate to be called by the emergency department here last year to say they had a male here who was on a second overdose in 7 hours, and if there was something that I could do to help. So I came in and agreed, finally talked him into going with me, and he went with me, and we brought him into treatment. I already had a bed set up with him for him when I was on my way here, and it was a mistake, and as I say, on our part, I wanted training for the guys who didn't search this male's room after the first overdose, because our guys are the ones that brought him in here at 11 o'clock at night. He gets released, he's back home at 3 in the morning, they go back there at 4 in the morning under another overdose because the drugs are still in the house. So now what we're doing is making sure we search the rooms. I mean, if we have a dog available, we'll bring a dog in. And the dogs are pretty awesome. I haven't seen anybody outrun one of our dogs yet either, so they're pretty quick. But at the end of the day, please, my number is readily available. If anybody has any questions, you can call me. I do a safety presentation for doctors' offices as well. My wife's a doctor. I actually went into her office and sat down with all the staff and told them what to look for. Personal safety. If somebody comes in acting irate, what they should do, I'll call 911. And last but not least is two of the other things that we've done, which has been very successful, is I made pamphlets for funeral homes to give to people when they come in to set up the funeral arrangements, to say, call me, let me come and get the narcotics out of the house. Because more times than not, I'm coming across people with prescriptions from their grandmother, uncle, whoever who had just passed away. They know the house is vacant. They go in there and take it. Real estate agents. Went to real estate agents, gave them the same information. When you're going to show a house, make sure that people are securing these narcotics, because, again, we're coming across these pill bottles, going back and talking to the people, hey, we found these in this car. Do you know how they got there? And they're like, no, I have no idea. I had an open house on Sunday or whatever it was, and these people admitted that they go and they look for open houses, especially when it's an older home, because they know older people have it, and they go and take the narcotics. So it's we do all sorts of little fun stuff like that. So I'm all set. Have a good day, folks. Oh, yes, sir. How many calls a week? I would say, the numbers as of this morning, I just checked, we're at 117 fatal with 715 overdoses. And we had 2 of them, I believe it was 2 of them yesterday, is where we are. So it's tough to give you an average. I'd say 1 to 2 a day, depending. Some weekends are extremely busy. We had one weekend where we had 14 overdoses, and with 4 of those being fatal, all centralized in the town of Greece, were the fatals. So that's something we look at to see if we can tie that into one particular dealer. So that's it. Any other questions? Oh. Sir.
Any information how marijuana will
So the question is, any predictions on how marijuana will impact all of this? The certainty here is that marijuana will impact all of this. I've given hour-long talks on the issue of marijuana, and I think the debate so far has been around, is marijuana legal or illegal? And I think particularly in healthcare, we need to focus on, is marijuana healthy or unhealthy? Because those are not necessarily, the same questions. It is clear that marijuana is an addictive substance. And to the extent that addiction is a disease, irrespective of what it is that you're addicted to, any addictive disorder will feed another addictive disorder. And I think we've got to be very careful about how we approach marijuana. Now, to be fair, marijuana has been around a long time too, just like opioids have been. Why is marijuana illegal? Because we made it illegal. It is the same cannabis sativa that we've known all along. But marijuana has a very storied history. And if you go back to the 1930s, there were movies that were dramatizing, if you will, marijuana use in a very in a negative way. Let's put it that way, stigmatizing people of color. Marijuana is a Spanish-sounding name, but there's nothing Spanish about marijuana. It was named that to essentially stigmatize other people of color, and that's why it's called marijuana today. But anyway, that's a digression. This will impact the crisis of addiction for sure, and we are seeing people dying from vape products, as you all know. Some of these vape products contain fentanyl, and we've got to be very careful about that. Sir?
A very common fact that I found in all the pictures that you were showing is the needles. Widespread availability of needles to get administration. And then one of the needles you mentioned was providing. Is there a plan or a certain thought of how to address that piece in order to mitigate the usage?
Yeah, that's unfortunately, it's a little bit beyond of what law enforcement can control on where they get this product from and how they're obtaining those. You know, it's dealers really don't like to talk to us as much as we really push them on, you know, where they're getting this stuff from. I mean, it's a great question. Is, you know, how would we curb that? And they'll just find another means. And a lot of people that I work with, they snort it. You know, they won't inject. So I mean, they're going to just find another means to do it. So it's you know, it's a good question, but we don't have anything in the works right now on how to curb that.
But on the topic of needles, I think needles have become a symbol of a problem, in addition to being a problem in and of themselves. You know, obviously, needle exchange programs have been shown through evidence to decrease the incidence of Hep C and HIV. Period. And it's a harm reduction approach. I wish we didn't need to distribute the needles, but the reality is that we do. And Trillium, I would say, is one of the leaders in this community. And unfortunately, they have been demonized because they have become synonymous with the visual part of the problem, which are the needles. And it's a very real problem. Don't misunderstand. But how do we get the needles out there and how do we clean them up? We have tried to put kiosks out in the community. And the first people who object to them are the community because they don't want that problem there. And I get that. But at the same time, you know, where do we draw the line? How do we, you know, we don't have the resources to pick up every needle, so we've got volunteers doing it, and God bless them. But it is a major problem. Yeah, you did.
What are your thoughts on like safe injection facilities and sites?
So that's a common question. First of all, I will say that there is no such thing as a safe injection site. Supervised injection is what I would prefer to call it. It is what I would say, you know, on the harm reduction spectrum, it is, you know, a little further out there. I think it's important to understand them. It's important that there are places that are experimenting with this, Albany, for example. You know, in the health department, that's not something we're involved in right now. But I am open to the knowledge. I think we need to study this. And if it's shown to be, you know, beneficial, obviously there can be a lot of controversies around this. You know, to have a government-sanctioned drug use site is not going to go over very easily, no matter what political stripe you are. So that's something that we've got to look into, though.
What proportion of primary care providers in this community prescribe Savata?
So we looked at claims data to try to understand that question. It's hard to know, and we can probably get the data, but a lot of people have been waived, and I think only about 10% of those who have been waived are actually prescribing. And of those that are prescribing, is it one or two, or really taking care of people chronically? It's really not enough. That's the point. It's not enough.
So
Yeah.
To get back to that issue of Savata, you presented it correctly that it's no different than any other medication. So have you presented that argument to the legislators who insist on the prerequisite of going through the certification program?
So.
And if you have, what was their response?
So Data 2000 is the federal law that requires the waiver. It's a federal law. And so that is something that is happening in Washington. The ASAM, American Society of Addiction Medicine, is advocating very strongly for eliminating the waiver. And it's hashtag X the X waiver. I mean, it's a movement, and we're trying to support this, but it does live at the federal level. It's a DEA policy. Sir.
Piggybacking
So in the health department, and we're just a fraction of the Narcan, we've distributed 3,000 Narcan kits through direct training. A lot of other organizations in the county are opioid overdose prevention centers, so they can distribute Narcan for free. We will certainly not be able to reach all 750,000 people in the county in that way. So what I want you all to know is that anybody can go to a pharmacy right now and get Narcan. You do not need a personal prescription. You do not need to see your healthcare provider. There is a standing order, essentially, across the entire state that allows anybody to go in and get Narcan. Now, if it is a medication, you do have to go to the pharmacy counter. Because it's a medication, it's subject to your insurance policy. But in the state of New York, there's a program called the Narcan Copayment Assistance Program that allows up to $40 of your copay to be waived. It'll be billed to the state and then not to you. And so for most people, your copay is not going to be more than $40. You can get Narcan essentially free of charge. Sir?
Yeah, I know you're trying to shift more into primary care for management of trauma. In fact, there's a serious shortage of primary care. How that is not.
Yes. So I will come back another day and talk about primary care workforce shortage. But I'll leave it at, in the state of New York today, estimates show that we are 866 primary care providers short right now. In the 2019 MASH, we graduated 3,000 future family doctors. So if you do the math, 3,000 new people entering the workforce in 3 years, not to mention the 3,000 every year that leave the workforce through retirement, we are never going to meet the primary care crisis with primary care doctors alone, let alone addiction. My point is that we need to look at how we engineer care. And team-based care is how we go. And that's why I talk about scope of practice only a little bit here, but I think it's a big deal. Why is it that in the state of New York, you need to be a nurse or an LPN to give a shot? In Illinois and California, where I practiced, MAs can give immunizations. We own this problem in New York. We are a little different here in New York. And we've got to address these scope of practice issues because we are never going to get through any workforce shortage if all we do is dig our heels in and say, no, we must do it. Sir.
How do you protect children in Monroe County from ACEs, and if they are subjected to ACEs, how do you heal them to prevent becoming addicts?
So that's a complicated question. The question is really how do we prevent addiction through the attention to ACEs? So when you hear social determinants of health, I want you to think poverty and racism, because those are the two social determinants of health. Almost all social determinants of health find their roots in poverty and racism. So how do we address poverty and racism is really the question, because I think that is the root cause for not all, but some of the people who are at risk for addiction. Now, the rest of us may not be victims of poverty and racism and have an addictive disorder too. So it's not as simple as just addressing poverty and racism, but it's a big part of it. So I'll take one more question, and I want to be mindful of your time. Nobody wants the last shot? All right, with that, oh, sir, yeah.
Yeah, I'm a chaplain, so I'm not interested in, administering shots or anything, but
We can get you there, though.
I can't get away from the fact that this is fundamentally a spiritual problem. And, the move back to primary care, I think, primary care is spiritual care provider, a community pastor, rabbi, religious leader, and how, spiritual people can get involved in addressing sort of the underlying foundational problems.
Yeah, that's a good point. I think it underscores the importance of this being all hands on deck. I mean, taking care of people is fundamentally not just a medical issue. It's a community issue. And how do we weigh in on everybody across? I mean, healthcare is only 10% responsible for what predicts premature death in this country. Everything else is outside of healthcare. So we've got to figure out how do we engage other populations. So with that, I'm going to end here, allow you all to get on with your day. Thank you all for your attention.